Welcome to the Paediatrics Pointers, your ultimate revision program in the Paediatrics. This is your faculty, Dr. Ashutosh Aggarwal, and today we are like to discuss regarding the important topic of the cystic fibrosis. The cystic fibrosis, what is expected to be remembered, it is an autosomal recessive disorder. Autosomal recessive disorder, there is basically a cystic fibrosis gene which codes for a protein, CFTR protein, which is cystic fibrosis transmembrane conductance regulator protein. What does this protein regulates? This protein mainly regulates chloride ion and also bicarbonate ion. So if the examiner has given both in choice, you should always choose chloride ion. But if it is a multiple answer type of a question, you should choose both chloride and the bicarbonate ion. The gene is present on the chromosome 7q. It is the long arm of the chromosome 7 where the gene is present. Lot many mutations can be seen in cystic fibrosis. You need to remember one is a class 1 to 3. In the class 1 to 3, there is complete or near complete absence of CFTR function. There is no CFTR protein, or indirectly you can say there is no CFTR function which is seen. In class 4 and class 5, some amount of CFTR function is present. And mainly you should remember the two mutations. One is delta F508, which is the most common mutation which is seen in cystic fibrosis. There is misfolding of the CFTR protein, and in this there is deletion of phenylalanine at 508 position. You need to remember here three things. This mutation is a deletion of which amino acid? Phenylalanine, and at which position? 508. What is present here? Misfolding of CFTR protein. Then is G551D mutation. This G551D mutation is a class 3 mutation. In this, what happens? Glycine is replaced by aspartic acid at location 551. What actually happens here? You should think CFTR protein are just two gates of a channel. And to open the gates of a channel, the CFTR protein requires the support of cyclic AMP or ATP. So in this condition, CFTR protein is there, but that is not stimulated by cyclic AMP or ATP. So what you basically get is there is non-functional CFTR protein which is present in the apical surface. So these two mutations you should bare minimum know: delta F508 and G551D mutation. Now to understand the clinical features, we talk is the pathogenesis. What you should remember, the function of CFTR protein is organ specific. What we mean to say, we know CFTR protein regulates chloride ion, but the function is different in different organs. If you consider in the sweat glands, the normal function is to reabsorb chloride ion. The normal function is to reabsorb chloride ion. But if you consider the epithelium of the respiratory system, GIT and GUT, and this yellow color we have shown here, this actually is mucus. And normally over every epithelium, there is presence of mucus, and the mucus is watery. Now why the mucus is watery? Because the normal function of CFTR protein here is to secrete chloride ion. The function in sweat gland was to reabsorb. Here the function is to secrete chloride ion, which combines with sodium and keeps the mucus watery. So if you think cystic fibrosis, chloride will not go out. If the chloride will not go out, the mucus will be dehydrated. And this dehydrated mucus is going to cause obstruction. So there will be obstruction of respiratory system, obstruction of GIT, obstruction of GUT. So going on to the clinical features, the earliest feature in the lungs is the bronchiolitis, because first of all it is going to block the smallest airways, followed by bronchitis, followed by bronchiectasis, and you should specifically remember this bronchiectasis affects the upper lobe. Then there is pansinusitis. There is increased incidence of nasal polyps. There is increased incidence of respiratory tract infection, and most common causative organism in children is Staph aureus. In adults is Pseudomonas aeruginosa mucoid strain. And what you should specifically remember, which antibiotics can be given by nebulization route for Pseudomonas. According to the Nelson 22nd edition, you can give 4 antibiotics: levofloxacin, amikacin, tobramycin, aztreonam. Then there is also increased incidence of Burkholderia cepacia, and according to the Robbins textbook of pathology, this is pathognomic of cystic fibrosis. There is increased incidence of allergic bronchopulmonary aspergillosis. These are the features of respiratory system. In the GIT, if you consider the neonate, in the neonate what you get is meconium plug syndrome or meconium ileus. So a child has not passed the meconium for 48 hours. What is the next line of management to be done? Always remember gastrographin enema. This gastrographin enema is not only diagnostic, it can also be therapeutic. So you go for the gastrographin enema. If you will not do anything, intestine can perforate, meconium can spread in the peritoneum, that can become meconium peritonitis. In the children, reciprocal to that, there is distal intestinal obstruction syndrome, DIOS, which is the obstruction of basically the ileum part in the children. In the liver, there is biliary cirrhosis. Bile has become thick, obstructing the bile duct, damaging the liver. In the pancreas, exocrine pancreatic insufficiency, and if liver and pancreas both are not functioning, there will be fat malabsorption, and this fat malabsorption can lead to the coagulopathy. Genitourinary tract, in the males, there is absence of Wolffian duct structure which causes azoospermia. These are the main clinical features you should remember in cystic fibrosis. In the sweat glands, there is loss of sodium and chloride in the sweat, and due to the loss of sodium and chloride in the sweat, there is hyponatremic hypochloremic alkalosis. There is hyponatremic hypochloremic alkalosis. In the newborn, if you want to screen, there are now, according to Nelson latest edition, 22nd edition, 3 modalities. One you can measure is the immunoreactive trypsinogen enzyme, which is a proenzyme which is almost always elevated in the patients of cystic fibrosis. If this is positive, you basically go for the CFTR mutation. Another modality is you measure immunoreactive trypsinogen, again repeat after 2 to 4 weeks immunoreactive trypsinogen, and if it is also second time positive, it is considered to be screening is positive. Third is IRT-CFTR mutation. Any one of the 3 approaches can be used, and the point is presence of single CFTR mutation is considered to be a positive screen, not confirmation. How do you confirm the diagnosis? You can simply confirm by the sweat chloride level, which are more than 60 millimole per liter on 2 different days. Remember, one reading 70, one is 50 is not cystic fibrosis. Or 2 or more than 2 CFTR mutation or abnormal nasal potential difference. Out of the 3, any single criteria present makes a diagnosis of cystic fibrosis. Treatment, there are 2 drugs. One is CFTR potentiator, which will keep the gate of the channel open, and the potentiator is one drug, ivacaftor. Then are the CFTR correctors, which not only stabilizes the CFTR protein, they increases the trafficking to the cell surface. In this is lumacaftor, tezacaftor, elexacaftor. In G551D mutation, we are using a single drug ivacaftor. In delta F508, you can use iva plus luma, iva plus teza, or teza plus iva plus alexa. Right? So this was regarding the cystic fibrosis. Keep watching the channel. Do subscribe to this channel. This is your faculty, Dr. Ashutosh Aggarwal. Please do watch more series of the PEDS pointers. Thanks.